Well, welcome everyone. I appreciate everybody giving up a little piece of their Monday night. Big thanks to the physicians that are on as they're kind of coming back to share their stories to help you guys figure out in both your pre-med and in your medical school pathway what are all the cool opportunities that I didn't even know existed when I was a pre-med and a med student. So I'm really excited about tonight. I might have to go back and do a third residency and follow in Dr. Geisler's footsteps. Again, I'm Dr. Cox. I'm the dermatologist by trade. I'm working at USU as the assistant dean of recruitment, and we're working hand in hand with our HPSP colleagues. So big thanks to our physician recruiters and the recruiters that are online that will be helping you answer whatever questions you have in the breakout sessions. Just a few rules of the road. So the first hour, we're going to spend listening to some really awesome, engaging speakers talking about their pathway. And then make sure we'll tuck it into the chat again, but the handout, the flyer has all the breakout rooms. And so I'll try to linger in. And if people have questions about breakout rooms, then we can figure that out. But again, roughly the first hour or so, I think we'll probably run over listening to some great stories. In the second hour, make sure you get to the breakout rooms and get all your burning questions going. Thanks to War Docs for helping us recruit, as well as our course HPSP. And Dr. Mancuso, I will let you, I'll turn it over to you because I know a lot of your professional chapters are involved in making tonight happen. So thank you so much.
Great. Well, thanks so much, Austin. Appreciate the intro. And thanks to everybody for attending. It's a really great turnout. Today, we're going to talk about preventive medicine. The common theme for today, we have three different ABMS specialties: preventive medicine, occupational medicine, and aerospace medicine. And all three of those are preventive medicine, the American Board of Preventive Medicine specialties. The fourth one, tropical medicine, is thrown in as an affiliated global health tropical medicine area of interest for many of our folks in preventive medicine and affiliated specialties. So today's topic is preventive medicine in the military. We've got some great speakers with some really interesting careers and really interesting stories to tell you about. And we're going to lead off with Dr. Brit Geisler. She's an Army physician. She is an aerospace medicine physician, and her current job is as the group surgeon for the first Special Warfare Training Group. So I'll hand it over to Brit, and thanks for joining us today.
Thank you, sir. Thanks for that amazing introduction. So, like Dr. Mancuso said, I am an aerospace medicine specialist at the JFK Special Warfare Center and School. As of last week, I got a new title of command surgeon, so I'm doing that as well. So that's one step up from group surgeon. Yeah, so more responsibility, but also it's an amazing organization. So we are going to get in the quick agenda. Like, I'm going to talk about myself, and then I'm going to talk about the aerospace medicine residency, so that you kind of understand how that fits in my story. So this is an intro just to the Army Aerospace Medicine program from a graduate's point of view. Obviously, the obligatory, it's only my opinions. Things may have changed since I graduated. I graduated in 2024. And I know the amazing staff down there are continually pushing boundaries into more space exploration and doing great things down there. It does not reflect any views or opinions of the DoD, Army, or Department of Aviation Medicine. My story. So I did an undergraduate in microbiology at Oregon State University, and I went directly through ROTC. I went directly to USU for medical school. I can tell you that USU honestly is the only reason that I'm a doctor today. I had a pathway where I did have some trouble with step one, and I was decelerated. So I jokingly say it's a class of 08 reunion here because of many of my colleagues. But after my second year, I got decelerated, and I graduated in 2009. With USIS, they gave me opportunity, support, and they actually believed in me when I was having difficulties outside of just taking my USMLE step one, that is a beast. But I also got to bounce back. And the third time taking the step one, I graduated, I passed by a point. But my step two, with the support from USIS, I actually got like in the 94th percentile or something like that. So I can tell you that the people at USIS were a little shocked at my bounce back, but I can tell you that it is because of that organization that I'm sitting here today with doctor in front of my name. But I also took the opportunity in my 3 years of my clinical rotations to go to the flight surgeon course while I had time. And it was absolutely what influenced my life. I did an OBGYN residency at San Antonio at Sawcheck. And then after that, I went to be staff at Bain Jones in Fort Polk, Louisiana. While I was there, I deployed to Afghanistan, and that's where I kind of solidified who I was and where I was able to do good medicine in bad places. After Fort Polk, I went to be the OB chief in Alaska, Fort Wainwright, Alaska, and the military issued me a family. So I met my husband while I was deployed, but I had my son up in Alaska. While up in Alaska, I was able to get my expert field medical badge as a major, which is I felt old then. After that, I became the medical corps recruiting integration officer. I think Mary Alice might be online, where the Army saw me as a true believer, where I got to talk about the wonderful Army medicine and HPSP and those kinds of things. While I was there, I ran into some folks that I went to the flight surgeon course back in 2009 with, and they said, "Hey, Brit, how about this RAM thing?" And I was like, "No, I just got to Fort Knox. We just PCS." And then about a year later, I applied to my aerospace medicine residency. I love helicopters, and I really miss the operational Army. And really enjoyed my time down at RAM. It's in Fort Rucker, Alabama. I'll talk a lot more about it. And then after that, I got to SWCC. So that's Special Warfare Center and School. For the past year and a half, I was the first training group surgeon. So I was dealing with all the Army Special Operations Forces pipeline courses. So that is the Special Forces Green Berets, Civil Affairs, Psychological Operations, all of their pipeline and SEER. I was the kind of medical authority and the waiver authority there. Now I've gone a step up, echelon up, where I also deal with the medical training of our special operations combat medics and 18 Deltas or special forces medics, as well as the advanced skills, special operations advanced skills like dive school, the free fall school, and so on. Again, my kid has been there for most of the way. These are the two pictures of him at my EFMB pinning, and then I got to go to airborne school this year. So my 8-year-old was there and actually saw me do my last jump and got to pin my wings on it. So kind of bluff is like, I've been in a while. I've dealt with so many uniforms. I've had interesting experiences, and I still don't know what I want to do when I grow up. Here's pictures of me kind of early in my career. The far right was ROTC. So you see the BDUs back in, I think that's 2004. And the second one to the right, me looking messed up, that was Moulage. I think that was after first year, Kirkeshner, when we were moulaged and we were all patients for the Bushmaster kids. And then all throughout USIS, those are the two on the left are Bushmaster pictures. Again, there's been so many uniforms and so many iterations, and I still am friends with a lot of them, even ROTC to this day. And about me, my slides got messed up, but I've had so many experiences with my family. I've lived in places I could have never dreamed of, some better than others. My kid has had experiences and been probably more well-traveled than some adults. And I don't regret any of it. Again, we've bantered back and forth, but I've known Austin for 21 years. So if that makes you feel old, Austin, I'm doing that on purpose. Also, I've had once in a lifetime opportunities. And the big thing is I've never stopped growing. Picture on the left is actually me jumping out of an airplane. It was my 5th jump in airborne school in May. And my kid being very proud of me. And on the right, I got to do some medical coverage at Pikes Peak, where the high altitude research laboratory is. So I got to spend 2 weeks at Pikes Peak and experience things that probably very few people in the world has, because they shut it all down. So me and the research subjects were the only ones up there at night. So we got to run around and just minor mischief. So on to aerospace medicine. It is a subspecialty of preventive medicine, so that, we look more towards aviation and space. So what do we have? Kind of the who's. We do have medical students that come down to do rotations, research rotations. So if you're a medical student, currently, you can definitely do a rotation down at Fort Rucker, Alabama, so that you can experience what it is to kind of do aerospace medicine. We also do have a dedicated PGY1 slot. It was in Georgia, but I think they're looking to see where that dedicated slot will be going. It's probably going to another MTF, don't know yet. We do take people that are right out of their TY. So PGY1, since the program does start at PGY2, or your second year after medical school. So if you're a transitional year or a intern in another medical subspecialty, you can apply to be an aerospace medicine. And other physicians, like Austin joked about, that there are folks that come from other specialties. Me being an OBGYN, I'm the first one in the Army to do OBGYN and RAM. I know the Navy has a couple of them. So other subspecialists, family medicine, ER, we have GMOs, those kinds of things. So when we're talking about our community, and at least 2, yep. And when we're talking about our aerospace community, we are come one, come all. So we have opportunities throughout the spectrum of your career. It's a combo program. So in the Army, you do get double residency trained. Aerospace medicine is the first 2 years, and occupational medicine is the last year. So I'm double board certified in both. And you get an MPH while you're training. So lots of potential specialties you come out with. And you are very, very prepared for what the world has afterwards. So the whens, kind of, I already went through this, kind of what you do. You do your PGY 1 year. You could do a transitional year, or you can do the dedicated spot. It is now at Eisenhower, probably go to another facility. And then you have your AM1 and AM2 year. That's Aerospace Medicine 1 and 2. You complete your flight surgeon course during the first year, if you haven't already done it. And then you start your MPH, which is at the University of West Florida. Your second year is of your aerospace medicine year is when you do your capstone project and you graduate the program. We are the only program in the Army that when you start your occupational medicine year, you'll start to get your board certification pay, because you take your AM boards, your aerospace medicine boards, while you're an occupational medicine resident. And once you're board certified, you get board certified pay. So you complete your OM year and then you graduate. So it's double residency trained. You get your master's degree all within the program. Some of the courses listed, these are only, master in public health. So I apologize. So you get a master's degree while you're in the program. So again, lots of training, very employable. So these are just some of the courses, and these are Army specific courses. So when you're putting your kind of Army officer hat or Army Medical Corps officer hat, these are all courses that prepare you for the next level in operational medicine. So you have things like the Army Space Cadre basic course, so that you're prepared to be a space cadre or a space officer. And all these kind of programs and courses that help and look really good for the military side of the house. Where it is at the home of Army Aviation at Fort Rucker, Alabama, or LA. It's Lower Alabama. It is day trips away from lots of amazing places. It is a smaller town, but you're about 45 minutes away from Dothan. You're 2 hours from the beaches like Destin, Florida. If you've ever been there, it's absolutely gorgeous. About 4 hours from Atlanta, 5 hours from New Orleans. So it is a small place in Lower Alabama, but you get a lot of opportunity to fly a lot.
Yep.
Okay, so why? So why did I do it? Because I knew that it was gonna prepare me for operational medicine for a time in ForceCom or in the Army forces. It is a very small community. We have the ASMA, the Aerospace Medicine Association, meeting every May, and it is a big reunion. I saw Rob Krause there 2 years ago. You get a lot of DoD courses, so it prepares you to be an Army Med Corps officer, and it's just fun. Don't worry, I got lots of pictures. You're also double residency trained. You have lots of opportunities. Preventive specialties actually have the highest quality of life ratings of all medical specialties in space. Why would you not want to go to space, or at least be around space, or be near space, or go to Kennedy Space Center? And I'm a shuttle kid. Nowadays, the new generation loves SpaceX, but I absolutely love the space shuttle. So how do you apply? There is what's called a MILPER, or they post the instructions every single year at our HRC website. It gives you instructions, then you go through the application process, and it should be about completed mid-September. So most people that are going through medical school applications, it's kind of a similar process, but the Army has a centralized place for it. So lots of pictures. So when I talk about the civil life balance and seeing lots of cool things, we got to go to crazy places, got to see a bunch of NASA things. I got to fly a lot. And then you get to take cool pictures like this and show all your friends. And then you make friends for life. So as Julie Mendoza, she's one of my co-residents who previous family medicine trained, but now is, I think she's looking to take over some important positions that I don't think she has public yet. Again, helicopters are so cool. They're feats of engineering. They don't fly, they beat the air into submission. Just flying in helicopters is one of the reasons why, because I absolutely love helicopters. I missed them when I wasn't doing aerospace medicine, and it's what kind of drew me back. Lots of cool places, lots of cool things that you get to see. We get to see mission control at NASA. We got to go to the Johnson Space Center to do the space medicine course to learn about the physiologic changes in space. Again, putting the space into aerospace. Probably seeing there's Jeff Gordon. He's again an 08 class of 08 member. So again, a very, very small world. And one of the things I love about, yes, Dr. Elliott. One of the things I love about USIS is I didn't think when I was in aerospace medicine, I was going to run into one of my classmates. Again, this is the neutral buoyancy lab in Johnson Space Center, the big old pool that they practice. spacewalking, and it's just things that are the experiences that you get are second to none. I got to play with all the workout equipment that the International Space Station does. I got to get my deadlifts on, and my co-residents got to do a little bit more exercising, PTing all the time. This is looking at all the NASA's aircraft. You see on the left, that was Frank Rubio's helmet. This was during when he became the longest human to be in space. He was in space during this time, so I kind of was a little bit of a sly picture, but I thought it was really cool. He went to USIS, and he is a physician. Yeah. Again, sitting at when you talk about family, and family across the services in aerospace medicine, I actually like my Navy colleagues a little bit, but also you run into them frequently. And you get to have things in the aerospace medicine program. You get opportunities to present at national conferences, to publish. I got published twice in the asthma journal for Ask the Flight Surgeon. And then we just have fun. We have potlucks and celebrate Christmases together. And this is experiences that my kid also gets to have fun with. Crawling around on Blackhawks and seeing the inside of the Blackhawks, and coming down to NASA with me, and he's seen a SpaceX launch. Pretty much it is a unique program that a lot of people don't know about aerospace medicine. The opportunities outside the military are unique as well, but it really gave me the opportunity to have these amazing, wonderful things, as well as connect with people and the community and live a really cool life. I still do OBGYN, don't get me wrong. I love OBGYN, but this is so much cooler. And if I could do OBGYN, if I can continue for the rest of my life doing both, I would. So I'll be definitely in one of the breakout sessions, and feel free to ask me any questions that you want.
Great. Thanks so much, Dr. Geisler. You gave a really great presentation, a lot of cool stuff. I think we're going to hold questions till the breakout sessions. We've got another really cool presentation coming up from Dr. Hunter Smith. We've talked a lot about aerospace and flight medicine. Now we're going to switch gears and talk about tropical medicine and global health by Dr. Smith. So take it away, Hunter.
Great. Thanks a bunch. There we go. Great. So I'm Hunter Smith. Great to meet you, everybody. Going to talk to you a little bit about tropical medicine today. And so it's going to be a little bit different from the other talks in that tropical medicine is not a subspecialty of preventive medicine. It's not something you can get boarded in necessarily. It's more so a line of kind of medical public health practice that you can go into for kind of like scaling for your type of career, part-time, full-time, and a really broad array of ways that you can engage in it. But basically, so I'm a preventive medicine physician. I'm currently the focus area lead for antimicrobial resistant infections at the DoD's Global Emerging Infections Surveillance Branch, where I oversee all of the DoD's infectious disease surveillance projects on antimicrobial resistance, sexually transmitted infections, and enteric infections around the globe. So managing a $15 million portfolio across 35 projects in 30 countries. So very much global in scope, very much a tropical infectious disease focus. But I'll dive into that a little bit later. I think what's going to be valuable to start out with is kind of level setting to say, okay, well, what is tropical medicine in the first place? So I like this little bubble because it really starts to encompass a lot of these different aspects of tropical medicine. And broadly speaking, you're thinking about study, diagnosis, and treatment of diseases that are kind of more relevant to the global south, as we call it. And so these tropical, low and middle income countries. But I don't want it to strictly be considered in terms of clinical aspects. There's really a huge umbrella to consider under tropical medicine, and really under this kind of discipline of global health as well, which includes health systems and infrastructure, the public health aspects to it, a lot of kind of health diplomacy. The clinical aspect is certainly there. And I think when people think quick snapshot of tropical medicine in their mind, they think of going out and treating interesting diseases in interesting places in these kind of austere conditions. And that certainly can be a part of it. But I think it's what's valuable here for this kind of forum is really talking about what's the broad spectrum kind of menu of different ways that tropical medicine can manifest. And so just going through a few of these in terms of the diseases that are in conditions that are kind of most important for trop med. When you're thinking about the classic kind of big three in terms of HIV, TB, and malaria, whole variety of neglected tropical diseases like schisto and leash, emerging infectious diseases, which is what my current organization is really targeting. But thinking about, Ebola, Mpox, Zika, antimicrobial resistance, things that are either new diseases, SARS-CoV-2, or re-emerging diseases, diseases associated with poverty. And so I think there's a heavy emphasis on communicable diseases within the tropical medicine world, but really there's a lot that is also really important that is not necessarily communicable diseases when you're thinking about safe food and water in terms of malnutrition and vitamin deficiencies, nutritional deficiencies, but also in terms of, vaccine preventable diseases. And then really thinking about non-communicable disease as well, because that happens in these areas of the world too, when we're thinking about not just heat injuries, but COPD. You think about a lot of the ways that people cook and heat their homes at night. It's usually indoors with these kind of open fires, and that leads to a lot of COPD. And there's a variety of countries that are undergoing what we're calling an epidemiologic transition, where typically in lower income countries, you're seeing high rates of morbidity and mortality due to communicable diseases. And then in higher income countries, you see that shift over from communicable to non-communicable diseases, like in the US, where we have heart disease, cancer, diabetes, and all of these. But as you're transitioning, there's this epidemiologic transition where you're getting a double hit of both chronic disease and non-communicable disease and communicable disease. So I think it's important when we're thinking about tropical medicine that, yes, there's this like going out there in the wilderness and doing tropical medicine, and it's kind of like the sexy side of global health, but there's a whole world more to it as well. So why should you care about tropical medicine? I think, even if you're not going out into international contexts overseas or anything like that, you should really still care about trop med even in the US, because your patients can come from anywhere, particularly in a military context. So it's important to understand the epidemiology and etiology of diseases from outside the US. And I think another really important aspect to consider is that we're going to continue seeing more and more tropical diseases creeping up into the US with ongoing climate change, ongoing globalization. When you're starting to see screwworm climbing up, we used to have it contained to South America and via this kind of like aerial bombarding of neutered flies across Panama. But now they've broken through that barrier. They're starting to creep up into the US, and it could cause not just billions of dollars in kind of livestock damage, but also it can harm humans through really intense diseases like myiasis, where these flies, they lay their eggs in your neck or your skin, wherever they can make contact, and the eggs hatch and then crawl out through your skin, and it can be really painful. And one of my PrevMed mentors actually experienced that when he was in Central America. I won't out him, but yeah. So when you're thinking about squirm, we're thinking about Chagas disease, which is can be transmitted by these reduviid bugs, and those are continuing to creep up into Texas and the Southwest U.S. So really, you're starting to see a lot more tropical diseases in the U.S. And obviously, there's this piece of emerging infectious diseases where you're thinking about, even if you're thinking about the U.S. and global health security, a lot of these emerging infectious diseases, their origins come from areas where there's a human-animal environment interface where they intersect. Oftentimes, it's coming from these tropical regions when you're thinking about Zika virus or Mpox or Ebola or what have you. And then I think there's kind of this ethical call as well in terms of preventable human suffering. I think there's a lot of intersecting circles of interest and training for PrevMed folks in the world of tropical medicine and global health. When you think about like these really vivid public health emergency responses like to Ebola in West Africa, when you're thinking about prevention of disease and suffering, when you're thinking about health systems and health infrastructure and how to deliver care, get access to care, a lot of it is very much looking upstream and how can we keep people healthy before they really get sick. Okay. And then also importantly, why does the military care about tropical medicine? So I think first and foremost, you have to come with the understanding that disease and non-battle injuries have caused the majority of casualties in every single conflict in human history, more so than direct battle injuries and battle wounds. And until around the Vietnam War, more fatalities as well, more deaths due to disease and non-battle injuries. And when you're thinking about, for example, the US military, we have to be prepared to deploy to any part of the world at any given time. And oftentimes, our folks are getting deployed out and operating in austere conditions where you're exposed to these disease-carrying vectors like mosquitoes giving you dengue, malaria, yellow fever. We're thinking about sandflies transmitting leishmaniasis. And you see these guys camping out in the sand over there when you're thinking about, okay, well, there's a lot of transmission potential for leishmaniasis there. We're thinking about ticks like African tick-borne fever, rickettsial diseases, and tick-borne encephalitis, all these different types of diseases. And then also there's just the elements in terms of dogs and all sorts of other animals that can transmit rabies. You think about snake bites, heat injuries, and then also interactions with local populations, and whether it be diarrheal diseases, antimicrobial resistance, STIs. And a lot of people kind of undersell diarrheal disease, but especially in a global health context, it's still a leading cause of death worldwide. And if you look at the Military Infectious Disease Research Panel's threat prioritization panel, they consistently rank bacterial enteric pathogens as the number one threat to military operations every year. So it's critically important. So a little bit about my path to tropical medicine then. And I think it follows kind of a crawl, walk, run path. And really, I think people get interested in tropical medicine when they have kind of exposures and experiences to this type of thing, and leads them to want to pursue a career in that field. And so I think for me, I went to Tulane for undergrad, and I did an early acceptance program to their med school, creative scholars, and studied philosophy and religious studies and all sorts of fun stuff. And then did a combined MD and PH program at Tulane with my Master's of Public Health and Epidemiology. And so I did HPSP during that time, and then went straight through to do Preventive Medicine residency, where you can do your intern year in anything, anywhere. So I did my intern year in Honolulu, Hawaii at Triple Army Medical Center, which is also where I met my wife. She was a med student at University of Hawaii. and then finished doing my preventive medicine residency through USIS, and spent a lot of time at Hopkins as well. And so I think I saw someone in the chat ask, well, what happens if you already have an MPH? So I think I'm a good example for that, where I was able to do instead a Master of Bioethics through Johns Hopkins and the Bloomberg School of Public Health, as well as some additional coursework at USIS, such as the Certificate in Tropical Medicine and Traveler's Health. So starting out with the crawl, which was kind of like first exposures during college. So I was able to study abroad for 6 months at University of Cape Town, lived with a homestay family. And during that time, started really getting exposed, did some rotations and exposures to transplant surgery and emergency medicine, and really getting exposure to different types of health systems and the way different types of healthcare can be delivered. And so the picture you see there is Groote Schuur Hospital through University of Cape Town. That's where I was able to get a lot of transplant surgery experience. You know, they let you do a lot, holding the kidneys inside the patient and everything while they're stitching everything up. And fun fact, the first heart transplant in the world was actually performed by Christian Barnard at that hospital. And so just kind of introductory exposures. And I think it's also a good point to mention that you can get exposure to tropical medicine and global health at any stage of education or training, or during your professional career as well. And it just manifests in different ways. And I think this is probably my most like, here are pictures from my vacation slide, because I didn't have a whole lot. But bottom right, homestay family. Next to that is Cape of Good Hope, and then went to what's now Swaziland has been renamed to Eswatini. It's a small country kind of surrounded by South Africa, not Lesotho. Lesotho is completely encircled by that. And then a picture down there is kind of it's at Three Rondables. Okay, so right after that, went over to China for 2 months to do a public health study abroad. And I think, again, I really like hitting home the point where tropical medicine and in effect global health is not just about the clinical side to it. Part of it is, yes, but also about learning how the different health systems function. Learning how the care is delivered is also really important. And also what's critically important for when you're out there is kind of cultural competence. And I think the top right picture is the one that I can best highlight from this time, where in a lot of business and kind of international dealings with China, a lot of it is an expectation of drinking lots of beer at these buffets and dim sums and karaoke nights. So you meet a lot of terrific people. You make a lot of lifelong friends, and you develop a lot of cultural competence along the way to be able to navigate. What's the best way that we can be effective here? And so I think you'll see a few other pictures. There's Great Wall of China in the last one. We got Pyramids of Egypt in this one. So during medical school, I had the opportunity to rotate for 3 months as an intern at the World Health Organization's Eastern Mediterranean region headquarters in Cairo, Egypt, where I lived in an Airbnb under a bridge for 3 months and just walked to the office and back every day. And I think you'll just be so impressed with the level of dedication and competence of a lot of our international medical and public health colleagues. And, during this time, I was in their non-communicable diseases division, focused on cardiovascular disease. And looking at this through a scope of really country and regional and international level impacts, working with these highly international teams, it can be so rewarding, but also you really feel the impact of what you're doing to some respects. But yeah, I could talk all day about this, but we'll push on to residency. So during residency, as I mentioned earlier, I got a certificate in tropical medicine and traveler's health at USIS. And part of that training was you do a tropical medicine rotation. So I spent 5 weeks in Lima and Iquitos in Peru, doing my tropical medicine rotation at what used to be called NAMRU 6, but now it's called NAMRU South. And the Navy and Army each have 3 overseas public health laboratories that, as a physician, you could potentially get do an assignment at. If you're Army and Navy, if Air Force, you guys don't have any overseas public health labs, but there are still overseas opportunities. So for the Army, those locations are in Kenya, Republic of Georgia, and in Thailand. And for the Navy, they're in Singapore and Peru, and kind of scattered between Italy, Egypt, and Ghana. But as you can see here, even just from these photos, there's a variety of different ways that tropical medicine can manifest. Starting top left, you've got an outpatient clinic. Just to the right of that, we've got inpatient public hospital. Just to the right of that, we're speciating mosquitoes through the microscope, doing entomology research. To the right of that, you're in a more community field clinic. And I think, there's a lot of different considerations when you do these types of rotations, right? Where what are the best ways that I can be helpful and impactful and effective without it just being kind of a parachute drop, kind of like tourism rotation, right? And so there's a lot of ways that you can do tropical medicine rotations correctly and ethically versus others that are kind of more extractive rather than additive. And I think being able to go into the rotation with a lot of lead time and the right mindset is really important. And so first assignment out of residency, I went to Kisumu, Kenya, and it was 2020 through 2022, peak COVID pandemic times. And I was at the U.S. Army Medical Research Directorate Africa. And so during that time, there was it turned into the COVID Roadshow. Certainly, there was weekly meetings where I had to be the DoD representative for this interagency council on the global health security agenda for Kenya, meeting weekly with CDC, the USAID, with GITRA, and the Department of State, and a variety of other teams, where we're all kind of sharing our updates on, vaccine administrations from our side, our infectious disease surveillance findings, because we were doing a lot of SARS-CoV-2 surveillance, not just in Kenya, but also Uganda, Tanzania, Nigeria. And really here, a lot of that work, there was a lot of PEPFAR work as well, the President's Emergency Plan for AIDS Relief, which you get is I think about a $9 billion per year program across the globe. And there's a lot of military collaborations, as you can see in the bottom right-hand corner there, with the Kenya Defense Forces. And, a lot of the work was on research and development and clinical trials and being able to work with the communities out there, which was built off of years and years of trust. The reason the Army was out there in the first place was because they were invited out there in the 1960s to help support an African trypanosomiasis ongoing epidemic there. And so over the years, there's been this trust built up, not just country to country, but also within the communities with whom we partner with to do infectious disease clinical trials and research and surveillance. And really, I think that's a key part to tropical medicine for doing it right, is not just parachuting in, parachuting out, but being able to do sustained work and build relationships and build that trust. And before saying that, at the top, I should have also been like, I Dr. Geisler as well, to say that anything I say is just my own opinion, doesn't represent anybody or the government or DoD or anything like that. So next up, current assignment at Geis. So it's kind of the step up above the overseas public health labs to a more global scope. So I've been here the last 3 years, since 2022. And as I mentioned, I lead the portfolio for antimicrobial resistance, STIs, and enteric infections. And so this one is also another key highlighter for when you're doing tropical medicine, doing a lot of work in emerging infectious disease. The importance of maintaining relationships and communications and teams. And I'm in daily communications and emails and meetings with all of our folks spanning the globe, from Southeast Asia to Africa, Middle East, Eastern Europe, South America, just across the board. And you can see some of the highlights from some of our technical site visits that we've done over the time. Some of them are to our like high-tech reach-back labs in the US, where they do whole genome sequencing, advanced characterization, and bioinformatics analysis. And others are like, top left and middle, those are with the Georgian military in Tbilisi and Gori. And so it's taken us to a variety of places, and we've got Jordan and Ghana coming up this year as well. And if you want to read more about the type of work that we do at Geis and interested in working at or with us, we came out with a journal supplement in emerging infectious diseases last November. So put a plug out for that. And so we could talk about the clinical side a little bit more. So, for military context, as a military physician, there are certain contexts in which you can do clinical tropical medicine in overseas international locations. Some of them are through these global health engagements and kind of medical readiness and training exercises with host nations. I myself wasn't doing any in Kenya, but my wife, who's pediatric emergency medicine, she was certainly, she got her Kenya medical license and was practicing out there, seeing lots of malaria and burns and whatnot. But in the US, you can still do tropical medicine through the lens of travel medicine. And so I've been doing this the last 3 years, ever since I got back from Kenya, as an assistant professor at USIS, doing clinical travel medicine and teaching for the preventive medicine residents at Walter Reed. And so there's a few different phases to it. There's active duty, where you're helping make sure that they're meeting preventive requirements and recommendations for deployments, overseas assignments, TDYs, or even just for leisure. And you get to see veterans and beneficiaries too, making sure they're really, you're thinking upstream. We're preventive medicine. So we're thinking in terms of prophylaxis, like vaccines for yellow fever, typhoid, or what have you, medications for like traveler's diarrhea, anti-malarials, altitude sickness, and other forms of anticipatory guidance in terms of security, food, and these types of things. And when you think about it, Walter Reed, he's led that team that helped confirm mosquitoes as the transmitting vector for yellow fever in Cuba, along with Carlos Finley. So even that's going back to tropical medicine again. Now I'm closing out here, got 2 more slides, and really want to expand out the mindset in terms of, tropical medicine and what you do isn't just necessarily what your day job is. There's a variety of different ways you can be involved and engaged. And I think through your professional organizations is one way to do that. I'm very involved in 2 in particular, American College of Preventive Medicine. I'm on the board of regents there. And when I was the chair of the 2024 conference, created a global health track, because there's a lot of interest from our specialty to get more involved in that. And we continue to have a global health interest group going on at ACPM, where you can join and be more engaged and look out at opportunities there. I'm also involved in the ASTMH as the Treasurer Secretary for the Committee on Global Health. And ASTMH is where you can get a kind of official certificate in tropical medicine. You have to pass and take an exam to do that and have some prerequisites in place. And for us, for the military, almost all of our DoD overseas labs send a proportion of their researchers to come to ASTMH conference every year. And then finally, last 3 years, I'm also adjunct assistant professor at Johns Hopkins at the Berman Institute of Bioethics. And I put up this slide because I think one of the most appealing aspects to me about preventive medicine is the ability to keep your hand in multiple different pots and really pursue your passions, because it helps keep things fresh, allows you to prevent burnout, all while staying completely within your wheelhouse and specialty training. And so within my scope at Hopkins, we have this collaborative between Hopkins and Oxford working on global infectious disease ethics. And, a lot of my work focuses on ethics of antimicrobial resistance, emerging infectious diseases, military, global health. And I put that snapshot of the seminar series there just as an example where you can blend all your passions and interests together in really exciting and interesting ways. To me, I think preventive medicine is probably the best specialty with which you can do that. So that's what I got. Happy to take your questions in the breakout group, and see you there.
Great. Well, thanks so much, Dr. Smith. Hunter, great presentation. Very excited to have the folks talk to you after the conclusion of the presentations. Next up, we have Dr. Susan Ching. She's from the Air Force. She's going to talk to us about preventive medicine as a specialty, but more of the classical preventive medicine focus as opposed to the tropical medicine discussed by Dr. Smith. And she is currently the medical director of the Preventive Medicine 559th Training Health Squadron. So take it away, Dr. Ching.
All right, sir. Thank you. And a big welcome to everyone. Good afternoon and good evening. Thank you so much for the opportunity to tell you about the preventive medicine physicians in general. I will be speaking from a very Air Force specific bent, so apologies to that. But I did see some mentors that have hopped on from Army and Navy who should be able to help answer any questions if you are interested in that side as well. So just about me, I was an Air Force ROTC graduate, University of Delaware. And then through that, my detachment commander knew I was a pre-med and said, hey, if you're interested, we have a scholarship to go to med school. And I was like, tell me more. So I applied and actually got accepted for the HPSP program as a sophomore, which was fantastic because then I was able to apply to medical school already having the HPSP scholarship kind of in my back pocket. At the Des Moines University, which is where I chose to go to school, there was, I think in my my third year, I believe was a Dr. Beverly. She teaches in the MPH program. And she said, hey, you've probably never heard of it. There's a specialty called preventive medicine. If you want to know more, see me after class. And at the time, I was very interested in getting my master's of public health. I actually looked at doing it at the same time as my DO, but decided I couldn't handle the academic double dose. So went and talked to her afterwards and said, hey, how does one do Prev Med? What is this? Tell me more. And she recommended that I do some clinical time first. Now, as the other clinicians and physicians have discussed, that's not necessarily required, but it was what she recommended. So I chose to do a civilian PGY 1 year back at home in Delaware. At the time, that was because my now husband was stationed at McGuire as a pilot. And so instead of doing an active duty TGY 1, which would have been for me in the Air Force, the options were like Texas and California, I figured I'd try and stay close to him. So that worked out really well. Similarly, then I came on active duty as a GMO or a general medical officer flight doc. And so that meant that I just finished my PG 1 year and PGY 1 and went to McGuire, did flight medicine for a couple of years, and then followed my husband down to Laughlin Air Force Base, which is a pilot training base in Texas. While I was there, got to be chief of aerospace medicine, which is an SGP group level position, and decided while flight med was fun, Prev Med still had my interest, in the population health that I got to do actually during COVID really excited me. Some of the recommendations I made to our base commander on how to prevent COVID in our flyers, I wanted to be able to have that impact on a policy level and a broader scope. So applied for the active duty residency at UShoes, got my MPH over that 2-year program. Like the others have mentioned, it is a 2-year program after your PGY1. So as long as you do a clinical year in some capacity, you get to apply for your second and third years. And then just graduated actually in 2024. And I'm now down at Lackland, where I'm the medical director of preventive medicine. And my day-to-day job is basically in charge of the population of basic medical trainees. We are the only recruit training site for all of the Air Force and Space Force enlisted. And so we have 35 to 39,000 people come through the course of the year. It's about 800 a week that arrive and graduate. 800 sounds like a huge number, but I assure you we do manage it. And so my role on the team is to keep that population healthy and keep that machine working so that we can get everyone down to their tech school training and then supply really our Air Force members. So we'll go to the next slide here. All right, so just a little bit about the USU registry residency that I got to attend. It was 2 years, like I mentioned, kind of already, but one of the highlights was I was invited to do a podium presentation at MHSRS on my MPH project, which is a little hard to see, but it was about alpha-gal, which is a disease that we are now seeing across the US, that you get an anaphylactic allergy if you eat red meat. So imagine never eating beef. And they've found it's a causal relationship with those who have had a tick bite. And it's a very, very unfortunate and very frustrating that I see in the chat. I'm sorry about that because it's a very difficult diagnosis. So what I looked at is all of the recruits at certain training sites in the yellow to see whether or not their job had an impact on their likelihood to get it. And you're probably not surprised to hear that the people that are in the forests or security forces, boots on the ground for real, were more likely to get it than our finance and our administrative officers and enlisted members. So that was what I was presenting there. And that was really quite the highlight, getting to go down and speak at a very big conference. In addition, the residency program has Navy and Air Force. So you can see in the picture there's some of my co-residents during our graduation. And it's also international. So occasionally we have Canadian residents. And so you can see one photo there. We actually got to visit the Canadian embassy through the rotation, through basically our contact with her. And that was a really big highlight for me. And comparing how does the Canadian forces manage their population, because it is really interesting to see how they do population medicine slightly different to us. Also, kind of as a summary, did manage to get out 5 publications during that 2-year program. I had 2 that are peer reviewed and then 1 baby girl. So that's my second baby, but the program is very family friendly. So if you are coming to it later in life for whatever reason, I was able to take 6 weeks off with her and then graduate only 4 weeks later than my peers, but still managed to get the MPH on time. And so that was really something I'd like to put a plug in for those of you that might be coming to this later. The program is very, very family friendly. Okay, so life after residency, what does that look like? Very positive work-life balance. One of the things that I really noticed when I was talking to Prev-Med physicians is that everybody seemed happy and they seemed to like their job. And I noticed when I was an HPSP student on my active duty rotations that occasionally that didn't seem to be the case. There were specialties that I did rotations in that the physicians didn't seem to be quite enjoying their jobs. And I will say I do enjoy my job, but there's no on-call, there's no weekends. I also cover travel clinic a little bit and some flight medicine since I still have that credentials. And then I get to guest lecture like tonight and talk to students and other physicians, non-physicians about various things in the population and preventive medicine world. One of my favorite things to do, we'll talk a little bit more about, is site visits and outbreak investigations. And then as a result of that, sometimes we get published. So the CDC, one of their public health publications that they regularly release is called the MMWR. It's a little bit hard to read there, but if you go back onto their website in September, we had a publication there on an outbreak investigation we got to do in the basic trainees. And then also in MISMR, there was another article we published last year as well. So kind of in more specifics, what do I do kind of on a more general basis? I do clinic monthly. For preventive medicine, there's a good range on what counts as clinic and how much clinic you want to do. For me, it's monthly. That's a good fit for me. So I do a travel clinic for ages 2 and up. I like kiddos, so I get to see ages 2 and up, and then I'll do flight medicine as needed. Some Prev Med physicians do clinic more than 1 day a week. So it really just depends on your interest and what your assignment is in terms of how much clinic you get to do. But it can be a little bit up to you as well. If you want to do more clinic, there's that option. If you'd rather not, then for me, monthly has been a really nice balance. I do get to guest lecture quarterly. So I talk to the students that are going through the public health emergency officer course based on my experiences as a FEO is what we call it, for a public health emergency officer during COVID. And then talks like today, and then the Masters of Public Health and Prev Med classes I've been able to talk to as well. One of the other things that I did get to do as needed, which is really useful and allows you to sort of put on your clinician hat or your Sherlock Holmes moment, is investigations and site outbreaks. And so for me, that looks at basic training dormitories, going to the barber shop, gas mask training, and then the military working dog kennel. Here at Lackland is like the roll floor hospital for the military working dogs. And so getting to see exactly how do they in process the working dogs and get them trained is really incredible to see as well. Another thing we do in PrevMed is congressionally directed research. And so I talked to one of my Wright-Patterson counterparts and said, what's something you've been working on lately? And they were directed from a 4-star general to look at missile communities and the cancer rate. So if you're interested, there's a link there. I can send that to you also in our breakout room. But looking at very specifically, are there higher risks of cancers in those that are in the missile community? And then secondarily, here at Basic Training, we got directed by Congress. If you're not sure what that means, look at the little italics. This is the no later than the Secretary of Defense shall. That's actually how it went into the law. And basically that says that they will offer EKG screening for everyone at BMT and recruit training sites as they go through. So Lackland was one of the first locations to test trial that, and that way they can look at and report to Congress how many people are getting screened now out of the military due to something we found on an ECG, since that's not normally something that we are asked to do, but we do get to play a role on these very, very big projects, which is a lot of fun. So kind of on that same note, field epi is like your Sherlock Holmes moment of being preventive medicine. So at USAFA, which is the Air Force Academy, PrevMed Doc did some respiratory surveillance, which is to say looking at the bugs, those swabbing people and seeing like, do they have COVID? Do they have flu? What exactly are they sick with? And then also looking at air quality, wastewater, and sequencing all those pathogens to then provide information on how to keep those cadets healthy while they're in the field, like you can see in the photos. Actually got briefed to a 3-star general afterwards with those policy implementations. So one of the things in PrevMed, we do get to do very high level briefings, and our information gets routed up very, very quickly because it's regarding the population as a whole. Here at BMT, or Basic Military Training, we do respiratory surveillance quite regularly, COVID, flu, etc. And just last week, actually, we had the Deputy Assistant Secretary of War, as she's now called, for Health and Services Policy, Dr. Susan Osega, a retired 2-star admiral. I got to brief her and was invited to a conference next January to present that information to some higher level ups as well. So that's kind of cool. So future options in PrevMed, if you're just like, well, I'm not really sure field epi's for me, or the research side, we do have operational and clinical medicine billets, and those include commanders, what we call in the Air Force your SGH, your SGP, so leadership positions, very highly interested in what you have to offer as a PrevMed physician. Or you can go more research and surveillance heavy, like Dr. Smith mentioned, being overseas. We don't necessarily have that, but what we do have at the Air Force side at Wright-Patterson is the surveillance team. You can go into global health. So while we don't have an overseas base, we do have PrevMed physicians stationed overseas doing global health. And that's a very easy track for us to get on if there's an interest there. We have education billets and then policy billets at headquarters as well. As another note, some other cool things that PrevMed docs tend to go into is the the CDC EIS fellowship, which is kind of the footprint there on the globe. I do like it because that shows kind of how PrevMed does interact in general. We have a very global scale and global mind, but we also make a big footprint, even though we're kind of small. And then informatics is a new fellowship, which is done after residency. Our informatics preventive medicine program director might be on the call tonight. I'm not sure, but I can get you in touch with him if needed. They recently toured Microsoft, and that's based out of Seattle as well. All right. So in conclusion, PrevMed in general uses data to drive decisions. So you can see this little spike on the screen is where we at Basic Training noted that there was an uptick of influenza. It looks really big to you guys, but out of 6,000 people on the base, you can't tell, but that's 35, and 30 people out of 6,000 isn't going to get any commander particularly concerned. But my office was able to find out that that was actually all in one squadron. Visited the squadron, found out they'd ran out of their disinfectant, told them we recommend they use the appropriate disinfectant. And then very nicely the following week, you can see that spike going down. And then even subsequently following along back to the baseline after the flu shot was implemented. So just another example of ways that prevention via a vaccine can be just as helpful sometimes as an intervention. I like to say you get to develop your inner diplomat because we do work between clinical and non-clinical sides. Oftentimes our commanders are not physicians. So you need to be able to communicate the medical importance of why it's a big deal that there may or may not be an outbreak to somebody that maybe has some medical knowledge but isn't a doctor. Or similarly, medical to line, and explaining why to a line commander this is an important thing that they need to ask their troops to do or not do, depending on where they are. And finally, we get to directly impact debates, installation, local level guidance. Back in COVID, that was something I was very involved in, and we do get to continue to do that. For area and MatchCom is what we call major commands in the Air Force. We recently had a measles outbreak in Texas, and so was watching that very closely to see if there was any potential for somebody to bring measles to basic training. Could have been very challenging for us at the Air Force. And our research on measles actually went all the way up to our Surgeon General, creating a national debate about how to require some troops to get a measles vaccine when they haven't actually joined the military. So that was a really interesting conversation that we got to have as well. I'm happy to go into more detail with that one in the breakout room, but for the interest of time, I'll hold questions till the end. And I do thank you for watching tonight.
Thanks so much, Dr. Ching. It was a great introduction and orientation to preventive medicine and the varieties of that specialty. So thanks so much. Our next speaker is Dr. Marlon Tingzon, who is formerly in the Navy, now out of the Navy and working for Google. He is representing the occupational medicine specialty, and he's the global lead for occupational health at Google Data Center. So I'll hand it over to Dr. Tingzon.
Ground has you both loud and clear. You are clear forward and after clear to start two. 4.5 PG, good oil.
Loud. Warning.
Right. Hey, everybody. I hope you enjoy those short clips of myself doing the coolest things I've ever done in the Navy, from doing actual dogfighting in a training setting, flying over Lake Tahoe in an MH-60 Sierra, shooting a machine gun 50 caliber out of a helicopter, doing actual missions, doing mountainside rescues where I personally rappelled down a helicopter in 2 ravines to do training and actual missions. And finally, pulling Gs, flying through one of the many Star Wars canyons in the world, that one being in Nevada. So my name is Marlon Tingzon, and I'm here to tell you why occupational and environmental medicine is the best specialty. Now, I realize I just showed you lots of flight videos from my time as a flight surgeon, and that was definitely a part of my decision to specialize in occupational medicine. And actually, I am board certified in occupational and aerospace medicine. Yet I do think occupational medicine is the best specialty. Before I move on, there's some pictures of me when I was an ensign, when I became a lieutenant, and finally as a lieutenant commander. Right now, I've left the Navy. I was in for a wonderful 9 years. Due to some family matters, we decided to get out when my commitment was up. And I currently am the global lead for occupational health at Google. Now, I know this is a busy slide, but I wanted to put up front what my Navy journey was for 9 years. And so when I graduated medical school, I was a surgical intern at the Naval Medical Center in San Diego from 14 to 15. Really wanted to go through with surgery, but the Navy had different plans for me. And I happily became a flight surgeon where I PCS to Pensacola, Florida. I went through that curriculum. From 2016 to 2018, I went to Naval Aviation Warfighting Development Center, or NAVDC, better known as the home of Top Gun, or the United States Navy Fighter Weapons School, where I got to do all those cool things in the video I showed you. There, I was the senior regional flight surgeon. During that time, a lot happened, which I'll get into in a second. I ended up going to Walter Reed National Military Medical Center, 2018 to 20, to pursue occupational and environmental medicine residency. From there, when that time ended, the world had changed because of COVID. I was sent to U.S. Naval Hospital Sigonella in Sicily, Italy, where I was the occupational health physician as well as the public health emergency officer. All right, now before going on, I want to just highlight that I think I'm the only panelist today that is not in the Navy anymore. However, I miss it truly. It was a wonderful 9 years that really shaped who I am. And just some really quick highlights how the Navy was really a big part of my life. 3 pictures here, which really don't do justice for all the cool things I got to do. On the left, I got to be a part of a tropical medicine training mission where I went to Peru, and you can see me there feeling like I'm a Ghostbuster, but what I was doing was catching mosquitoes so that we can check if they have any diseases in them. On the right-hand side, I had an official orange Navy flight suit that I would actually use on real missions when we go search for people who might have gotten lost on a trail, or in Lake Tahoe where they might have lost somebody on a paddleboard. And in the middle, I had a wonderful military sword arch during my wedding, which was one of my favorite highlights of my Navy career. All right, so getting into a little of the meat of my presentation, why did I go into occupational medicine? How did I end up here? Which is a really twisty path. So I'll explain a little bit on the left, and I'll talk about some of the pictures you see on the right. And you don't go to medical school thinking you're going to go into occupational medicine. You might have had a great experience with a doctor who you met in the past, an amazing pediatrician, cardiologist, or surgeon, and like, hey, I want to do that. That is awesome. My journey was really growing up, but during undergrad, I thought insects were the coolest. I'd be collecting ants, I'd get ant farms, and I thought they were cool. I went to UC Davis, and there was a strong agricultural program. They had an entomology program, which was one of my minors. And I was like, I want to study infectious disease. I want to be a physician who can treat malaria, one of the biggest killers in the world still today. And so that's what I had in mind when I went to medical school. In medical school, hey, that OR is awesome. I like scrubbing in. I like fixing something right there and then, sewing it up, and then moving on. And you've really made a difference in someone's life for that day. So how about I do general surgery? And that's what I did. I went to San Diego Naval Medical Center, and I did a surgical internship. I loved all the mantras. Eat when you can, sleep when you can, don't mess with the pancreas. I like having a heart of gold, or feeling I had a heart of gold and iron feet and a steel stomach. Like I can do anything, like I was invincible. So that's the first part of the story. Here on the right-hand side, you can see me when I still had civilian hair. I still keep my military cut in the upper right when I first commissioned in 2010. There in the upper left, there's me in Fenway Park when I went through officer development school. A couple pictures in the bottom there when I went to C4, a training course. So as I mentioned, I thought surgery was still the coolest thing ever. However, I had an unexpected pivot where I became a flight surgeon. And during that job, I was keeping pilots healthy. I was preventing medical problems. And I realized I could make bigger impacts on health through policy and programs. Some pilots were injured. Some of these guidelines weren't up to date. I felt like people were unjustly having something happen to them. And me wanted to fight for my patients. I said, hey, if I could change things somehow, I wanted to do it. And so I was thinking that through policy changes is where I wanted to go and do medicine on a bigger scale. During the time I did earn an MBA, I did have time to do it during my flight tour, and I'm happy I did. I'll talk about the pictures now. There's me in a T-6 airplane, one of my first flights ever with the Navy. It was amazing. Right next to that, you can see me in an F-16, having the time of my life, pulling 9Gs. Bottom left, I was firing a howitzer cannon, helping the Navy SEALs spot where they want to put artillery downrange. And then there's me with that big 50 cal gun out of MH-60 Sierra. So during my flight tour, I was finding myself, I was finding my niche, and I did have a newborn child. So I sought what medical specialty might have a better work-life balance, which was ironic with COVID happening in 2020. But when you think of the lifestyle specialties, if that's maybe dermatology or ophthalmology, what I was already doing with flight medicine, I realized that was occupational medicine, and I looked into it a lot more. And I got mentors and friends who had done the path, and I never looked back since. With occupational medicine, I was trained with risk communication. So talking to people outside of the clinics, talking in town halls, hey, we have a mold problem. What are we going to do about it? You need somebody smart with clinical insight to talk about it. I learned about medical strategy. How should we implement a policy so that we are as encompassing as possible, but we still need to maintain standards. I was translating clinical insights for non-medical individuals. Hey, how does COVID affect us? I was talking to barbers. I was talking to hotel workers because of COVID. And that was a great experience that was outside of the clinic, which I really enjoyed. Okay, so what keeps me excited about occupational medicine? One, in general, there are lots of niches even within occupational medicine, and every role can be vastly different. So obviously, there's a military role with occupational medicine. If you are doing medical surveillance, you work at a submarine associated base, and you're doing ionizing radiation physicals. You might be working at a big medical center, like at Walter Reed, where I was at, or a civilian medical center. You might be in academics doing research on the latest isocyanate research or depleted uranium studies effects on veterans. You might be in private practice. Might be doing workers' comp, urgent care. You might be located next to a big plant where there's lots of injuries. I'm talking in heavy industrial sites that need that support right away, construction sites and the like. You could be in a corporate setting. And that's what I do right now is I use my background in medical policy to push different initiatives within a corporation. And when I say corporation, I'm talking like not just tech, but it could be an airline. You could be the flight surgeon for United Airlines, for example, Southwest Airlines. You could be working for a big pharma company or an insurance company. And I happen to be in tech. Some examples of applying medicine in non-traditional ways here, and these are things that I've actually done, are explaining what electromagnetic field radiation is and potential risks to small communities. I oversee the data centers at Google, and it's a very common thing we get as we pop up these data centers everywhere. Hey, how does this affect my health? What are you doing about it? Can you provide us with more information? And so I'll help with the public affairs team on that end. I might be recommending emergency response strategies for remote locations. We build our data centers in very rural areas all over the world. And so I work closely with vendors like International SOS on, hey, I need a solid recommendation. Do we need to build a helipad, an ambulance? Do we need to build infrastructure? Or should we go so far as to build a women's health clinic if that is the issue in the local community? Finally, another example is I advise non-medical leaders on high-stake health policies. It might seem pretty simple, but getting everybody on the same page when it comes to even hearing protection is a huge challenge. So talking to the right stakeholders, getting buy-in for why we're doing it, what's the associated costs, what about medical surveillance, who goes into those surveillance programs. There's a lot that goes into that, and I lead programs that have global change, just like I did in the military, especially when it came to COVID. Right. So this is basically my last slide here. What else keeps me excited? Having a global impact. So I think that any of us here who have been in the military are having a global impact. You're part of an organization, an enterprise that changes the world straight up. And you can do that on the outside of the military too. So it takes a lot of cross collaboration, doing a lot of policy setting that affects lots of people, thinking about those different populations that we're affecting. Is it active duty? Is it full-time employees only? Are we talking contractors? What about vendors? What about foreign nationals or the unions? That's what keeps me excited, balancing all those things. And it can be a big puzzle. And as physicians, we like to solve puzzles. And also operational readiness. It's not just a military term. Lots of companies need to be ready, whatever their mission is, if it's keeping commercial airlines, pilots all healthy and so that they can fly on schedule, or if it's in tech where we want to make sure that artificial intelligence infrastructure is running properly on a safety side. Those are some big impacts that I love to be a part of. And lastly, I can't not say that occupational medicine does have perks, lots with lifestyle. I do have a very flexible schedule. If you're not tied to a clinical schedule, you're set in policy, you're in meetings, you can set your own time for when you want to have meetings. And every day is different. I'm not doing workers' comp all day. I'm not sewing up lacerations or anything. But there's always a new different challenge that you don't think that you might have encountered before. And it's very fulfilling. And lastly, networking. In the American College of Occupational and Environmental Medicine, my colleagues sit with some really interesting companies. I'm talking Disney, Netflix, all the airlines, Comcast, NBC. Those are my colleagues, and we all talk about different struggles. A lot of us came from the military, not surprisingly, given our amazing training that we got. And so definitely a big perk working in occupational medicine and seeing what else is out there. All right. So I want to close by saying thank you to Dr. Mancuso and his staff. Wish I could be there virtually to talk to everybody. But please contact me if you have any questions specific to my journey, or if you want any advice. You can reach me at LinkedIn. There's my link there, or you could email me at marlontingzon@google.com. Very grateful for what the military has provided me. All the training is world class, and I wouldn't trade it for the world. And that's why I'm talking here, because I definitely want to get back to my community, and I'm always will keep my hand with my Navy and military family. So, thank you very much, and have a good day.
Yeah, real quick, just thank you guys so much. I appreciate everybody for showing up and giving us your Monday night. For next month, we'll highlight emergency medicine. We've got speakers lined up for, again, November 3rd, 6:30. Again, anyone and everyone's welcome, whether you're HPSB, USU, a pre-med, whether you're not even considered military medicine. So feel free to share the links and bring anyone and everyone in. A big round of applause for our speakers tonight, for Dr. Mancuso and the Preventive Medicine team at USU for pulling together a really great show, set of speakers. Thank you.